Hello, and welcome to this presentation from the Multiple Sclerosis Foundation. My name is Casey Minnis, the Director of Communications for the Foundation, and I will be your host today as we are joined by our Senior Medical Advisor, Dr. Ben Thrower. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at Shepherd in Atlanta, Georgia, and we're delighted to have him today to present on the topic of an update on COVID-19 for people with MS. Dr. Thrower, with that, I'll turn it over to you.
Awesome. Thank you, Casey, for hosting this afternoon. Thank you to all of your colleagues at the MS Focus. You guys do a wonderful job. And thank you to all of our participants for joining in with this. So I will confess up front, I am not a virologist or a COVID expert, but I think all of us have had to learn a lot about COVID from our own personal health standpoint, and certainly from the standpoint of how COVID affects the MS community. I wanted to really do three things this afternoon. I wanted to sort of just give an overview of where we're at with COVID in general, talk a little bit about prevention and treatment, and then we'll launch into how COVID vaccinations and those topics interact directly with multiple sclerosis, and then we'll leave plenty of time for questions and hopefully answers as well afterwards. So we've had an interesting past few months. The Delta surge of COVID hit the United States hard. I think when we look back and we saw what was happening in, say, India, it was largely predictive of what happened in the United States. The COVID Delta numbers, really shot up exponentially here in the United States. And the good news is they do appear to be coming down in much of the United States, particularly in the Southeast. For any of you who are not maybe familiar with a number called the R naught, capital R and then a little zero afterwards, it's an epidemiologic term. And so it's important to think about, because what R naught does is it gives you a sense of how contagious something is. And so when we think about the alpha variant of COVID, the first variation of COVID that really hit globally, the alpha variant had an R naught number of about 2 when it was at its worst. And what that means is that if you had one infected person, that one infected person could infect 2 people over here, and so on and so forth. The Delta variant, in contrast, had an R naught of about 7. So that meant one infected person infected 7 people, infected 49 people. And so that's why we saw that exponential growth. It was just so very contagious. Again, it does look like the numbers are coming down. Here in Georgia, we follow the numbers on a daily basis. What you want to see to show that the pandemic is going the right direction is that the R naught number is below 1. And so our numbers here in Georgia, and I believe it's similar in our surrounding states, the numbers have been around 0.45 for well over a month now. So I think, God willing, we're on the right track. The unknown, I think, for all of us is, could we see another variant pop up? Hopefully not. Assuming we don't, maybe we're on the right track to putting this behind us. We're not at 0 yet. And so we still need to be vigilant. And so when we think about, strategies for preventing COVID, how can you keep yourself from getting sick in the first place? Well, vaccination is obviously probably the single most important thing that we can do. As most of you know, we have 3 options here in the United States. We have the Pfizer, the Moderna, and the Johnson & Johnson product. This is an evolving field. The FDA is, opening up vaccinations to younger and younger people. I think eventually all 3 vaccines will be approved for children and adults. Right now, Pfizer's a little ahead of the game and having started their pediatric studies earlier. But I do think we'll reach a point where all 3 are probably approved for children and adults. There is, interestingly, there's a little bit of confusion sometimes when we start talking about third doses versus booster doses, and now you're even hearing discussions of fourth doses of vaccinations. So when we say a third dose, or if you were talking about the Johnson & Johnson, because that's a one-shot vaccine, that would be a second dose. Well, when we use that term, we're referring to someone who might not have a totally normal immune system. Maybe you're on a medication that might compromise your immune system. Maybe you have some other health issue that compromises your immune system, and you're doing 3 vaccinations, if we're talking about Pfizer and Moderna, in rapid succession. So a third dose of a vaccine can be given as soon as 28 days from your second dose, or 28 days from your first dose of Johnson & Johnson. You're trying to generate as much of an antibody response as possible in someone who might be prone to not generating a good immune response. That's in contrast to a booster. The booster would be that term we would use in someone that has a relatively normal immune system. And this is where we're going to think about doing another dose 6 to 8 months from your original vaccine series. And so those, the FDA has now given approval also to mixing and matching. So you can, in theory, if you maybe received Johnson & Johnson and now you want to do Pfizer or Moderna, or you did Moderna and for some reason you want to move around, you do have that option. Personally, I'm still a little bit of a purist. I would prefer to stick with the same product. My wife and I, for instance, did Moderna. We've done our booster doses of Moderna, and to me, it was just more appealing to stay with the same product throughout. So when we think about prevention, I think vaccination is your number one weapon against fighting back against COVID. Masking in appropriate situations, I still think is something we need to think about. If you're in a higher risk group, use common sense when you think about going into large gatherings. Don't put yourself in harm's way if you don't have to. These are all things that we have to struggle with. I get questions every day from someone saying, "Hey, I've got a wedding coming up, and it's in Utah, for instance, and is it safe to go to?" It's hard to know how to advise people with specific questions because there is no zero risk option. Anything that we do is going to have a little bit of risk associated with it, and we all have a risk tolerance. Something that might be acceptable to me might not be acceptable to someone else. I ride a motorcycle. That's an acceptable risk to me. I wear a helmet when I do it. I know people that don't wear helmets. That seems silly to me. That risk is acceptable to them. So we all have our own risk tolerance and things that we're going to have to use some discernment to see what's okay for us and what's not. There has been some interest in off-label things to potentially lower the risk of COVID. I don't think we've talked about this much in the past, but people do ask about it. For a while, hydroxychloroquine was the hot topic, and then ivermectin was the hot topic. These are tough discussions because there are a lot of medications out there that were designed to treat one health problem that may have effects in other health problems. We use things off-label all the time. We use antidepressants, for instance, in multiple sclerosis to treat pain, even though that's not what they were designed to do. Just because something, though, works in the laboratory and looks good in the test tube doesn't necessarily mean that it's going to work out in the real world. So clearly, both hydroxychloroquine and ivermectin do have antiviral effects in the laboratory. The question, though, is can we reach high enough concentrations in the real world that it would really be a preventative? And I don't think we have good evidence to say that we do. So I'm very open-minded. I'm scientifically curious, and I think the problem that we've had during the pandemic is so many of these topics got politically charged on both sides, and it's sad that happened because we really should be able to have a scientific discussion without attaching an R or a D to a medication. I would not widely recommend people think about ivermectin or hydroxychloroquine as preventatives, just because I don't think there's enough data out there at this point. And I think we have things that might work better. So what about treating COVID. So let's say that you actually have contracted COVID, you've tested positive for it. Probably one of the most effective things we have right now are the monoclonal antibodies. And so so Regeneron would be an example of that. So if you are significantly symptomatic with a COVID infection, going and getting an infusion of these monoclonal antibodies is safe, effective, and pretty widely available to get treated with. Pfizer has now published their data on their pill that just came out. The data just came out within the past week or so. This oral medication is best used early in the course of a known COVID infection. And I wrote the name down here because I've just not seen it enough. So Paxlovid or Ritovinar, I'm totally messing this up. Ritonavir. It'll take me a few times to get that right. Ritonavir is an oral medication, 3 pills a day, twice daily for 5 days, and appears to be about 90% effective at reducing the risk of hospitalization or death. That is wonderful news. It appears to be very well tolerated, low side effect risk. So it is anticipated that probably before the end of the year, that medication is going to get emergency use authorization and gives us one more apparently very, very effective tool to help push back. There is another oral medication from Merck Pharmaceuticals. It's getting a little bit more attention in Europe, but there are potentially 2 oral options out there available. So So I think the key is, if you think that you might have COVID, it's probably worthwhile getting tested quickly to confirm or rule out. Just because we've been in the midst of a COVID pandemic doesn't mean there aren't other viruses out there. You can still get a common cold, you can still get influenza, and it's probably worthwhile knowing what you're dealing with so that you can treat appropriately. So how does all this then tie into multiple sclerosis directly? So what we know with the vaccinations, and this goes back to really when the vaccines first came out, we know that the vaccines are safe for people with MS. People with MS appear to have the same risk of side effects from vaccination, in particular these vaccinations, that the general public does. Are there side effects with these vaccines? Yes, every vaccine known to man has some small risk of side effects. You can feel crummy, flu-like, achy, low-grade fever. There are rare cases of autoimmune reactions to every vaccine we've known. You can see Bell's palsies and Guillain-Barré syndromes, but people with MS do not appear to have any different risk of those things than the general public. In general, we think it's a good idea for people with MS to get vaccinated. There are some specific challenges that we have. So some of our disease-modifying therapies can potentially affect the effectiveness of vaccines. Probably the class we worry about the most would be our B-cell therapies. So this is going to be Ocrevus or ocrelizumab, rituximab, also Truxima is a biosimilar to rituximab, Kesimpta, ofatumumab is in that class. These medications work on B cells in your immune system. One of the major jobs of B cells in the immune system is to make antibodies. And so it's not too unusual to realize that these medications can affect the ability of your body to make antibodies to the COVID vaccines and potentially other vaccines. So what we know from studies is that if you're on a B cell therapy, there's about a 50% chance that you're not going to make a good antibody response to COVID vaccination. It appears that everyone on B cell therapy does make a good T cell response. So that's the counterpart to B cells in our immune system, or the T cells. And those are antiviral as well. So it does look like people do make a good T cell response. We don't have an readily available commercial assay to measure T cell responses to vaccination. There is one out there called T Cell Adapt, but we've looked into it here. I'm sure other centers have looked into it. It is not very easy to order that. I can check your antibodies to COVID vaccination very easily. That's a simple blood test. It goes to Mayo Clinic, get it back in a few days, but checking a T cell response is a little bit more difficult. So what do we do with that information? I still like to see people on all therapies, all of our disease modifying therapies get vaccinated. I think if you are on a B cell therapy, I would very much like to see you get a third dose of a COVID vaccine. I think that people on our S1P drugs, these are your oral, your Gilenya, Mayzent, Zeposia, and Ponvory, I think it's worth getting a third dose as well. There's a little bit of a timing issue when you think about B cell therapies. What research has shown is that the further you are away from your B cell infusion of Ocrevus, for instance, the more likely it is that you are to get an antibody response to your vaccination. Personally, for me, this was a little bit surprising because when I look at my B cell therapy patients, their B cells are depleted before I give their infusion, after I give their infusion, 3 months after I give their infusion. So intuitively, I would not have thought that it would make too much of a difference when we think about the timing of your COVID vaccination as it relates to your Ocrevus infusion, but the studies said otherwise. They said that if we can put some time. So we get into this delicate dance. On one hand, we would like for people to be as protected as they can be from COVID as soon as they can be. So I'd like to have people get vaccinated as quickly as they can. On the other hand, we'd like to put maybe, a couple of weeks or more in between your infusion and your vaccination. There are now discussions about fourth doses, and I would say right now I would have people sit tight on that. I would like to see some guidance from some of our immunology and virology colleagues on, is that something that we really need to do? On one hand, I get that a fourth dose might be more likely to generate an antibody response for you. On the other hand, if you've truly generated no antibodies with 3 doses of a COVID vaccine, is the fourth dose going to do the magic trick? There was just if you go on CNN's website, there's a story about a gentleman, I think he's an organ transplant recipient. He's immunocompromised, and it's a story about this very thing, someone receiving multiple doses of a COVID vaccine and still has no antibody response. So I don't know what the right answer to that is. I think, in those individuals, we may call it a day after your third dose. Maybe we do a fourth dose, but I think we want to also supplement that with just a healthy degree of common sense, masking and social distancing until we're confident that we're through this COVID pandemic and we're at super low risk for those individuals. I think for those individuals, the monoclonal antibodies in this new Pfizer pill are going to be just so very important. If we can't completely rely on vaccination, maybe we need to have a backup plan. We hear discussions from people with MS and from people without MS about vaccine hesitancy, and whether it's choosing a disease modifying therapy or helping someone decide on COVID vaccination, I feel like our job as healthcare providers is to be your guidance counselor. I may twist your arm a little bit to get COVID vaccination. I may twist your arm a little bit to go on a disease modifying therapy. Ultimately, it is your decision. I just want to make sure that you're making your decision based upon really good information. There are some myths and misinformation out there. We hear sometimes young women express concern about fertility issues with the vaccines, and there has been no evidence that these vaccines have any effect on fertility whatsoever. People have expressed concerns saying, well, listen, during this Delta surge, I hear that people who are vaccinated are still getting COVID, or they're still transmitting it to other people. And both of those things are true. So with the original Alpha variant of COVID, the vaccines were tremendously effective at keeping the vaccinated person from getting COVID or transmitting it. The Delta variant's a little different. It is, because of that R naught number, it is more contagious. So it is possible for a person who's vaccinated to get COVID or transmit it. But what the vaccines do a really good job of is keeping you out of the hospital and keeping you from dying. If you look at hospitals around the country during the height of the Delta surge, the overwhelming majority of people who were in the ICUs or unfortunately dying were the unvaccinated. So even though the vaccines weren't perfect, they did really help in terms of keeping people out of the hospital or keeping from dying. When our hospitals were horribly overwhelmed, and you had poor ER nurses and doctors and respiratory therapists just working 100-hour weeks, keeping people out of the hospital was vitally important. So again, hopefully we are on the right path for putting this COVID pandemic behind us. We're not out of the woods yet. I'd love to throw it open to what thoughts and questions you guys have about what you're seeing, what concerns you have.
Thank you, Dr. Ben. So now we will take questions from our audience. I'd like to let everybody know, if you have a question, there are a couple of ways that you can get that question to us. You can use the Q&A button at the bottom of your screen to submit a question. You also have an option there to submit it anonymously if you would like, or you can use the raise hand button to ask your question, and I'll give you the option to unmute and ask your question live. We do have a few questions to begin with. Our first question came in from Facebook, and it was from Luann, who would like to know more about using monoclonal antibodies as a preventative. She says she's had 5 doses of Pfizer and still no antibodies.
Yeah, so I would imagine she's probably someone who's on either a B-cell therapy or something that is preventing her from making a good antibody response. So just so that I mean, there is still a great chance that you have a T-cell response. And so that it's not that you're completely unprotected from COVID. So we don't think of the monoclonal antibodies necessarily as a preventative, that it's more treatment. So yeah, so if you were to have a proven case of COVID, I would strongly encourage you to get in, talk to your primary care doctor, find out where your nearest monoclonal antibody infusion center is at, and get in and get that treatment as quickly as possible. Again, I do think there's an excellent chance that in the next couple of weeks, we're going to have the Pfizer oral medication. So that's going to be an interesting sort of option. Which do we do? It's probably going to depend some upon availability, but I think 5 days of an oral medication is pretty appealing also. And again, it appears to be 90% effective. So it'll be interesting to see how that shakes out. Right now, I don't know how I would choose between a monoclonal antibody and the Pfizer oral drug. They both appear to be very, very effective.
And Luann wanted to clarify that, yes, your assumption was correct. She is taking Ocrevus. Yeah. We have another question from someone particularly pertaining to Ocrevus. That is Kathy, who said she had her 3 vaccinations. She got COVID, got monoclonal antibodies, and finally tested negative, although she's still feeling lousy. She says she's due to get her Ocrevus infusion this month, and she asks, best guess, how likely is it to get reinfected after Ocrevus? This virus is nasty.
Yeah, so I think with the B-cell therapies like Ocrevus, it has always been important that we monitor immune function. With the COVID pandemic, that importance has ramped up several times. So I like to make sure that people are getting their total lymphocyte count checked. So Ocrevus should only affect the B cells in the immune system. And when we measure that with a blood test, we're looking at the CD19 count. So we expect someone's CD19 count to be 0 or close to it. That's what Ocrevus is supposed to do. What I like for people to do is also get their T cells checked. So we're looking at CD4 and CD8 counts. So those are your T cell subsets. Those should not be lowered by Ocrevus. If they are, we need to think about backing off on the dose or pushing the interval out. So the other thing that we check is your IgG levels. So that's just your not specific to COVID, just your total IgG or antibody levels. So those should not be low. Sometimes they are on Ocrevus. So the things that would make me want to maybe modify someone's Ocrevus dose, lower it, push the interval out, or even think about the other options would be if the total lymphocyte count is low, if the CD4, CD8, the T cell subsets are low, or the IgG levels are low. Any of those things for me is going to be the sort of the cue to think about modifying that treatment regimen. We have lowered the dose in a lot of our Ocrevus patients from 600 milligrams every 6 months to 300 milligrams every 6 months, just because one of those parameters was just a little bit off. So the good news, if there's a silver lining to her having had COVID, is that's essentially another vaccination, and maybe even better than a vaccination. So the antibody repertoire that humans generate to natural infection does appear to be a little broader than the antibodies that we generate to vaccination. So a lot of the Delta variant, the reason that we think that we were seeing breakthrough cases with vaccinations is the Delta variant was really reproducing in our nose and mouth and throat. IgA antibodies, a class of antibodies that's really prevalent in our upper respiratory tract, is not generated in large amounts with our COVID vaccinations. Natural infection does ramp up an IgA response. So you could argue that, not that we want people to get infected, but there could be a silver lining to it. We just don't have enough data yet in her particular situation. Someone on a B cell therapy, vaccinated but no antibodies, and now having had natural infection to give her an absolute number of what her risk is. The risk is not zero. And so even though she's been through all of this, I would still exercise caution, mask up when she's out and about, just staying away from large crowds, and then making sure that all those immune parameters are being monitored through our healthcare team.
Our next question is from Nicole. And this is, I think, somewhat theoretical, because she said it's too soon to make a call on a fourth dose. But she says, if someone doesn't seroconvert after the third booster of an mRNA type, would it make sense for their fourth dose to be the J&J?
Yeah, it's a great question. I don't know the answer to that. So it's interesting, J&J, so it's viral DNA that then ends up producing messenger RNA. So you could say it ends up being a messenger RNA, vaccine. So you're making messenger RNA to make the COVID spike protein. So in my gut, if you made me bet money, would I bet someone who didn't make antibodies to Pfizer or Moderna, would I think they would make antibodies to J&J? I would bet not. Again, like you're saying, it's theoretical. I'm sure we're going to get data on that, but I wouldn't be overly optimistic that switching to the J&J with a slightly different, mechanism is going to be the magic bullet. We lost her.
Our next question is from Barbara. She asks, given that a primary symptom of COVID relates to high fevers, could even a reasonably mild COVID infection cause several days of high fevers, cause exacerbation of MS symptoms?
Yeah, it's a great question. So we know that viruses are not the friends of people with multiple sclerosis, that we see pseudo exacerbation. So if you have a viral infection, the fever that you get, even if without a fever, one of the things that viruses do is they ramp up something in your immune system called gamma interferon. Gamma interferon is, you need it to kill the virus, but it's not a great thing for MS. Those pseudo exacerbations, though, typically don't leave behind either new lesions on MRI or permanent disability. So we call them pseudo exacerbations because we think it's usually old lesions that are sort of being manifested into generating symptoms due to what your immune system is trying to do to fight off the virus. So it's a legitimate concern, but I don't think it's likely to be a long-lasting issue. What's interesting to me with COVID is, and this is a blessing, is why we've not seen more pseudo exacerbations in people with MS. We've seen them, but I would think everyone that gets COVID, because of the fever and the immune response, I would think everyone with MS that gets COVID would have a risk of their old MS symptoms acting up. It's actually been the minority of people that have had that. And I can't explain why that would be. We've certainly had plenty of people with MS get COVID, but they seem to be riding it out fairly well. And so, yeah, whatever's causing it, we'll take it.
Okay, now we have a question live from Karen. Karen, go ahead and unmute and ask your question.
Hi, thank you for taking my question, Doctor. I have been on Kesimpta for the last year by advice from my neurologist. I did pause it in order to get my Pfizer vaccines, and I did not have any, had a negative 0.6 as of after the 2 doses, but then after the third, it came up to 5.92, and that's just whatever Quest does is the COVID spike protein, that's the antibody test. So I took that as good news, but did I break through the finish line? Now am I, just like everybody else? And I've obviously continued with my Kesimpta. Is there anything else that could happen? Can I assume that I've done everything I need to do?
I think you should be well covered at this point. So that's great that you did finally make an antibody response with the third dose. So the great thing is, once you do make an antibody response, the Kesimpta is not going to wipe it out. So you've got those memory cells now, the memory B cells, so they should spring into action if you were to see the COVID actual virus in the future. So that's great news. Yeah. So the only thing I would just kind of keep your ear to the ground and see where the science shakes out on fourth doses, and I think the other hard question is, do we monitor antibodies, long-term on patients? A lot of immunologists say, the antibodies in everyone, whether you're on a B cell therapy or not, whether you have MS or not, the antibodies are going to wane and go away. Does that mean we're truly not immune, or are there still memory B cells there, even though the antibody levels have dropped from that initial vaccination? Are there B cells there waiting to spring into action? Some of the work that was done at the University of Washington earlier this year, they looked in the bone marrow at people who had COVID, and even though their antibodies to COVID had gone away, they still had these nice memory B and T cells in their bone marrow waiting to spring into action. I don't think many of us are going to line up and want to have bone marrow biopsies to show that you have immunity, but there's still so much of the science that's not quite settled. For right now, you're good to go.
Okay, I guess my concern was, it seems like there's some viruses that you needed to be tested for, things that once you're on this could reappear to make you more vulnerable, hepatitis and some of the other things that I was tested for, we were all tested for before going on the medication. There's nothing that would, I'm not saying this correctly, there's nothing that would reverse. I wouldn't go back.
No, you really shouldn't.
Okay.
So the issue with hepatitis, with the B cell therapies is you could have someone who has a sort of an occult infection, the virus is there lingering in your system. And now, we knock your immune status down, and now that virus goes from being inactive to active.
I see.
So that's a virus that we're trying to see, do you have it in your system, before we put you on the drug?
I see.
Whereas COVID, it wouldn't be something that would be living in you right now. Right. We worry a little bit about herpes viruses, chicken pox and things like that, because those are also viruses that we carry in our body basically forever. You can't get rid of the, a herpes virus. So we typically do a little bit of testing to make sure that you still have some antibodies to chickenpox, for instance, before we start some of our immune therapies.
Right. Okay. Thank you.
Thank you for your question, Karen. Okay. We have an anonymous question in the Q&A. It says, can I donate monoclonal antibodies? I've had COVID, but I've had both of my shots.
Yeah, to the best of my knowledge, yes. I mean, it's funny sometimes with multiple sclerosis, the Red Cross years ago wouldn't accept blood donations from people with multiple sclerosis for fear that you're somehow going to transmit MS through blood, and we know that's clearly not true. So now they're accepting those donations of red blood cells. I can't see any reason why you wouldn't be able to. They're probably going to look at the medications that you're on, and so there may be certain medications that they're not thrilled about having people, but yeah, I would certainly go down and check out your Red Cross and see if if you can donate, because we certainly need the help.
Okay. I want to remind our listeners that if you want to ask a question in the Zoom, you can use the Q&A button, or you can use the chat, or you can use the raise hand feature. We have another question from Facebook. Marlene asks, would you recommend a booster if you had a breakthrough case of Delta?
It's another great question. So, and we see this come up frequently. So with, you have a natural infection, I kind of count that as a vaccination. So let's say you had 2 doses of a vaccine, and now you have a breakthrough Delta case. I think that counts as a vaccination. You are generating an immune response. You'd probably want to wait about 90 days from that natural infection before you think about a booster. Again, I wouldn't discourage people from seeking a booster dose after natural infection, but I would put some time between it, because you are going to have some natural immune response. So for people that are not thrilled about doing a booster, the way we've had some of those people walk that line is say, okay, I don't want to do a booster. I had a breakthrough Delta infection. Why don't I just monitor my antibodies? I'll do antibody testing once every month, once every 2 months or so. And when I start to see my antibodies dropping off, then I'll do my booster. I don't think that's a totally crazy idea. A little more hassle, a little more monitoring. I think the risk there is, what if you waited too long between, doing your blood tests and you had an exposure then? So a lot of different paths and that we can go down in this pandemic.
Our next question is from Katie. She says, hi, Doc. The pill that you take for COVID, that we hope will be available soon, will it work on any variant, or will they have to change it to whatever is spreading at the time?
Yeah, unlike, a monoclonal antibody, which is a very specific immune therapy, this is something that's more stopping viral replication. So right now, there's no indication that it's variant specific. So that's one nice thing about it. Now, if we're having this discussion 5 years from now, that may be different. So we do know that over longer periods of time that, viruses can, become less sensitive to oral antivirals. Amantadine would be a great example of that. Amantadine's an old anti-influenza drug developed back in the 1960s and 70s, and it was used to stop viral replication of influenza. Over many generations, that drug has become ineffective, and so that's not something that we use for influenza anymore. We use it to treat fatigue and MS as a quirky side effect of the drug, but I don't think it's a short-term concern with the Pfizer oral.
Okay. Thank you. Our next question is from Nicole. She says, and I'm not sure about the premise here, but she says, if we're constantly being exposed to COVID, aren't we getting challenged constantly and should be generating a response if capable? How is the booster better than this natural exposure? Are we getting natural exposure?
So it's not like, common cold viruses, where you do get, tons of it. If you have a kid in daycare, for instance, well, they're always bringing different, respiratory viruses home. I think COVID's different. I don't think we're getting a constant low dose of exposure to COVID. I think her premise that the immunity from natural infection is maybe a good thing, I think is true. The question is, can you get that immunity without it killing you or making you really, really sick? So if you could promise me that I could have a natural infection of COVID and that I was only going to be feeling crummy for 24 hours in the way that I might say with a vaccination, maybe that's an okay trade-off, but we don't have that guarantee. There is the chance, even in healthy young adults, that you could get very, very sick with a COVID infection. So my wife's a pediatrician. Most of the kids and teenagers that she saw that got COVID did fine. They were a little sick. They missed a few days of school. They're quarantined. They're good to go. But there is this MIS-C syndrome that we see with COVID in kids, even sometimes in healthy young kids. There's the myocarditis that we see in teenagers, with COVID. So yeah, I get where she's coming from. I just don't know that we're smart enough to predict who's going to have a mild COVID infection and get the natural immunity and they're good to go. I'd still rather take my chances with the vaccine than the natural infection.
Our next question is from Joseph. I'd asked for some clarity and have not heard back about what he means by bad reaction, but just as a general question, do you still recommend the booster if I had a very bad reaction from second dose?
Yeah, that's a great question. And it's I think your follow-up question is correct. How bad of a reaction? So, if someone was hospitalized due to a vaccine reaction, I'm probably not going to have them get a booster dose. Our son, with his first dose of a COVID vaccine, he has asthma, and he had a really bad asthma flare-up after his first dose of Moderna. So we had him not get any more after that. So there are a lot of gray areas in there. I would say if it was a severe enough reaction that, if you were, out of commission for a week, or again, you had to go to an urgent care emergency department, hospitalized with your second dose, I might pass on a booster in that individual.
Thank you. Our next question is from Kathy. She says, is the antibody test people are getting perfected for people with MS? I heard a few months back from Dr. Giovanni that it wasn't. I really have no idea.
Yeah, I mean, none of these, so the vaccines, these, the oral medications, the tests, none of these have been specifically largely tested in the MS community. So the one of the quirky things about clinical trials is a lot of times they're looking for people who don't have any health issues other than the one thing that they're studying, and it's a weakness of clinical research. It's great to have a group of healthy 18 to 55-year-olds, but not all of us are healthy 18 to 55-year-olds. People have other health issues, hypertension, diabetes, MS. So we have to then extrapolate what we think these tests and treatments will look like in different health conditions, or we see what they look like in the real world. I can't think of any reason why the antibody testing would be more or less sensitive or specific in the MS community. Again, your treatments may make you less likely to make the antibodies in the first place. And there is a certain sensitivity threshold that these tests are set at. So maybe if you're on Ocrevus, you make an antibody response, but it's at a very, very low level. It may be below the sensitivity of what the test is set at. That's the only way I can really think of how the MS would specifically interact with the antibody testing.
Okay, and our next question is from Betsy. She asks, do you have any advice for COVID positive MS patients?
So it really depends upon how symptomatic you are. I mean, we see individuals who are COVID positive And the only reason they knew they were positive is because they went in for a procedure or they were traveling. And so they just have to do the usual quarantine procedures that anyone else would who's COVID positive, do whatever your healthcare team tells you to do, just so that you're not going to get somebody else sick. If you're symptomatic, that's different. Then we're going to start thinking about treating your COVID. I think, again, my thought in the MS community is I want to be as proactive as possible. I want to keep that person out of the hospital. If I have access to monoclonal antibodies or the Pfizer pill in the near future, I probably would be pretty proactive in trying to get people treated if they have MS and they're symptomatic. If they're completely asymptomatic, I think it's okay to sit tight, watch, do your quarantine, and maybe you're one of the blessed individuals who's really going to have minimal, if any, symptoms.
Let's hope.
Yeah.
Our next question is from Scott, and he says, any thought on suspending B-cell depleting therapy so the vaccine can generate antibodies?
Yeah, I mean, we are obviously having that discussion with people. We're talking about what is the benefit you're getting from your B-cell therapy versus what's the risk. We clearly are affecting the effectiveness of the vaccines with the B-cell therapy. One group of individuals that we've actually taken off of B-cell therapy might be older individuals with primary progressive MS. So if you're 65 years old, you have primary progressive MS, you're on a B-cell therapy like Ocrevus, is the benefit you're getting really worth the potential risk? Because that's a high risk group for getting really sick with COVID, the older individuals. Maybe we don't stop the drug altogether. Maybe we just delay treatment. Maybe we push the treatment back 3 months or so. We dose Ocrevus and Rituxan every 6 months, but it's not like your B cells magically repopulate at 6 months. A lot of our individuals, when we measure their B cells at 7 months, 8 months, 9 months, they're still depleted. So I think there is wiggle room in a lot of our individuals. A lot of individual variability in there. We do see other individuals who repopulate sooner than 6 months. There was a study that looked at the African-American community and said that in general, with B-cell therapies, they seem to repopulate their B cells more aggressively than other groups of people. So that may be a group of individuals that we want to be a little cautious about holding their therapy or lowering their dose.
Okay. Our next question, actually, we have a hand raised from Debbie. Debbie, go ahead and unmute yourself. Let me give you a second more. If you can press the unmute button on your screen. Okay, we'll try and come back to you, Debbie.
Hey,
oh, there you go.
Usage up a lot more.
Hey, Debbie.
Yep.
We can hear you now. Go ahead with your question.
Hey, stay down.
Okay, we are going to move on, and hopefully you can type your question into the chat. All right. Our next question says, are most doctors checking antibody levels? And if my antibody level is high, can it go lower?
So I've not seen any data on how aggressively people are being in checking the antibodies. And it probably depends upon what therapy the person is on also. I mean, we do know the antibodies drop over time. So just, and that's going to vary from person to person. And again, like we said earlier, I'm not sure we know for sure what the dropping antibodies mean. If you never made them in the first place, like with a B-cell therapy, clearly that has one degree of significance. If you had great antibodies and now they start going away over time, does that mean that you're not immune, or are there memory B cells that are still waiting to protect you? And again, I don't think we know the answer to that quite yet. So I would rather have high antibodies and have them drop down over time versus never make antibodies at all. Because if you didn't make antibodies at all, you would have to assume that you never made memory B cells to protect you in the future either.
Okay, Joseph came back and clarified his question about the bad reaction to the shot. He said, after the second Moderna vaccine, I woke up 4 a.m. struggling to breathe. My primary progressive symptoms were twice as bad from bladder incontinence and spasticity. It took about 6 hours before things started settling down. Would you still recommend getting the booster even though I had this bad reaction to the second dose?
And that's a tough call. The struggling to breathe kind of concerns me a little bit. The other thing to realize is that if you're doing a true booster with Moderna, the Moderna booster studies were done with a half a dose compared to the original dose. So your first 2 doses of Moderna were 100 micrograms. A true booster dose of Moderna is 50 micrograms. Would you do better? Would you do okay with 50 micrograms, versus the 100 that you got up front? I don't know. You could have the same severe reactions. I think if it were just the neurological part and you were willing to tough it out and for 6 hours, I would say we could probably, and you've got good care in the home, someone there to be with you, help with transfers if you need it. Maybe we could tolerate that. The shortness of breath worries me though. I would, my gut feeling was I would probably pass on a booster in that situation.
And we have a question in the chat from Jim. He says, Doc, thanks for taking the time and doing these sessions. Do you have thoughts on mixing Pfizer and Moderna for the booster? I have Moderna vax 6 months ago.
Yeah, I think between Pfizer and Moderna, I mean, when you look at their mechanisms of action and their data on effectiveness, they're really, really similar. I think I've always felt Moderna has a slight edge. I don't personally see any huge advantage to mixing and matching with Moderna and Pfizer. I would probably stick with the same product. If it was a supply issue, so you let's say you receive Moderna and you go for your booster and they don't have Moderna, I'd certainly be okay with you getting Pfizer. But I think to do it purposefully, I don't think it's wrong to do it. I'm not sure I see any advantage to doing it.
Okay. Our next question is from an anonymous attendee. They asked if you could please explain herd immunity.
Yeah, so the idea with herd immunity is that, so let's say that I can't be vaccinated for some reason. I have side effects to the vaccine. Well, maybe if enough people around me, everyone in my cohort, my friends, my family, my coworkers, if they've all been vaccinated or they've had the natural infection and they have immunity from that, then I'm protected because they're not getting sick at that point. There was a lot of discussion early on when the vaccines first came out. How many vaccinated people do we need to have in the United States, versus natural immunity? When you add those two together, what's the magic number for us to hit herd immunity? I think what threw a monkey wrench into that to a certain degree was Delta, because all of a sudden Delta comes along and it's not an all or none. It's not like you can be vaccinated and I'm absolutely protected against Delta, or I've had COVID and I'm absolutely protected against Delta. So that herd immunity got a little squishy in there because Delta didn't play by some of the same rules that the Alpha variant did. But that's the concept, is that you have enough, you're not vaccinated, you've not had natural infection, but you have enough people around you who have had one of those two things that you're protected just by default.
Okay, our next question is from Mildred. She said, I had Moderna immunizations in March and April. Sadly, I had a breast cancer reoccurrence in August. My understanding is that chemotherapy destroyed my immune system. Would a booster be advised? I've had MS since '83 and am no longer on MS drugs.
So I would certainly run that by your oncologist. My suspicion is they're probably going to recommend that you do get a booster. So the good news is that the chemotherapy that you've got now doesn't wipe out the memory cells. So you had your immunizations pre-chemotherapy. So you have memory B and T cells for immunizate for the COVID. The question now is, because your immune system's a little lower with the chemotherapy, would it be beneficial to get a booster? And then if you do, what's the timing of that relative to your chemotherapy so you get the most benefit? I'd give your oncologist a call, but my suspicion is they're probably going to recommend that you do get a booster.
Okay. And Mildred, we're sorry that happened to you, and hang in there.
Yeah, good luck to you.
Okay, an anonymous attendee asked, how is the vaccine given? Is it in the muscle?
Yes, all of our vaccinations are given intramuscular. So whether it's Johnson & Johnson, Pfizer, Moderna, so they're, quick intramuscular shots.
And having had all of mine, I can tell you they don't hurt.
Yeah, not a big deal. I mean, you're going to have a sore arm at the injection. So it's not the shot, it's just the effects of the vaccine there. Yeah.
And we have a question from Karen. She says, what is your opinion about the COVID home tests like Binax now? For instance, is there a benefit in having family members test themselves before visiting?
I mean, I don't think that their sensitivity is quite as high as the professional tests that are run by LabCorp and our other lab, but it's certainly better than doing nothing. So I think if we're coming up to Thanksgiving, for instance, if family members didn't want to go and get tested at a regular through blood testing, I think it's certainly a useful tool. They're relatively inexpensive, they're painless. So yeah, I don't think it's a crazy idea to think about doing that.
Well, that is our time for today. Before we close, I'd like to remind our listeners, if you missed any part of this presentation, you will be able to watch it from the Foundation's Facebook page, or within a week or two, it will be added to our YouTube channel. You can subscribe to the channel to get updates anytime that we post a new video. And of course, that's free. We do have more teleconferences coming up this month. I would like to tell you about our next one. It is called Art is for Everyone. It is a workshop for people with MS with the artist Hannah Celeste Garrison, who is a mindfulness in arts instructor who happens to have MS herself. And that will be November 16th at 7 p.m. If you'd like information about how to join us, you can visit our website at msfocus.org or follow the Foundation on any of our social media. So now all that remains is to thank all of you, our listeners, for joining us, for your thoughtful questions and your attention, and especially to thank Dr. Ben Thrower for taking the time to share all of his knowledge and information with us on this complex topic. We appreciate you so much, Dr. Ben.
Thank you. Everyone have a wonderful day and a great upcoming Thanksgiving.